Hi, this is Brian Kim. I'm going to share with you this case of a patient with a 4+ dense cataract. And the pupil's nice and big at the beginning of the case, but then you'll see I have sudden intraoperative floppy iris syndrome that manifests with iris prolapse. And so you're going to see this technique. I'm going to place a single episcleral subincisional stab incision and then place an iris hook. And just this single iris hook is going to allow me to finish this case, an otherwise pretty dense cataract here. So I use a cotton tip to steady the eye, and then I use a corneal marker, which will help me to center incisor rectus. I turn the eye with a cotton tip, make my incision with the paracentesis blade, first on the right side and then the left side. The incision is going to be flat to the iris plane, which will create a nice corneal shelf and allow me to achieve a self-sealing incision. This is some intracameral lidocaine and then some intracameral epinephrine to stabilize the pupil. And this is some dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. So far, no indication for IFIS. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. I push some more viscoelastic in, place the teeth of the forceps sideways, go in, puncture the center, pull down, grab the right side of the tear to create a flap going around circumferentially, trying to use the mark that I made as a guide for the size and center of the rhexis. Go ahead and burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. I want you to pay attention. I'm going to make a nice slow wave here. Look how slow it is. It's a slow wave, and then look, the iris pops right out. And so clearly there was some pressure differential, and it caused the iris to come out. So I push down on the posterior edge of the incision, and the iris pops back in. So whenever you have iris prolapse, the key is to equalize the pressure inside and out of the eye. And so the only way to do that is just to push down on the incision, and it decompresses the eye, and then the iris goes back in. So this is the technique. I'm using my diamond blade to create a single episcleral stab incision subincisionally, going through the conge and then the sclera. And then I'm going to place this iris hook with the forceps, making sure I get around the iris but not around the rhexis. And so it's perfectly around the iris, not involving the rhexis. I'm loosening it up just a little bit here. But you can see I have a really nice and retracted iris now. That will not prolapse any further now that I've placed that hook there. Go ahead and loosen up on the left side, and then I'm going to turn the candida down and to the right. I'm trying to do some hydrodelineation again. Again, it was futile. I didn't get a hydrodelineation at all, again, due to the density of this lens. Irrigate the surface of the eye, adjust my sleeve length here, lifting the incision with the chopper, going in with irrigation off to minimize decimase trauma. I'm going to remove the surface epinuclear material here, place the chopper under the rhexis edge contra-incisionally, place the phaco tip vertically subincisionally. I'm able to get a nice grip of the lens, grabbing it and cutting it, bringing the instruments together, and then dividing the lens completely. You see I'm cracking and making sure both halves are separated. I place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, and then fracturing the right heminucleus in half. Using some vacuum to hold that first quadrant, getting the chopper around it, trying to chop that lens into smaller bits, and then removing those smaller fragments. Crushing that one fragment between the two instruments and then emulsifying it. So I'm getting around that second quadrant with the chopper, pulling it centrally towards the phaco tip with another cross chop maneuver. I'm able to bisect that second quadrant in half and then grabbing that fragment, crushing it into smaller pieces, and then emulsifying the lens pieces. Getting around that fragment with the chopper. Having some trouble there, so I'm going to go after a different piece. So I grab that piece with some vacuum, lifting it up, bisecting that lens piece in half with the instruments, and then emulsifying the lens pieces. So that's another cross-chop maneuver, dividing that fragment in half, crushing that fragment between the two instruments, and then emulsifying the lens pieces. This is a really dense lens, but you can see that iris is stone cold stable, no iris prolapse whatsoever. So I'm trying to get around that one fragment. It's kind of turning on me. Trying to use a little bit of vacuum. And then I placed the chopper around the lens piece. I was able to cut it in half there. And then I'm slowly removing those small fragments. So this is the fourth quadrant, the final quadrant, turning it in front of me, placing the chopper around the lens piece, getting around the girth of the lens. Oh, it didn't work. So let's try again. Get around the girth of the lens, placing the finger tip deep, which definitely gets both instruments around the lens, and then I was able to crush it and divide the lens. Getting around that fragment between the two instruments and crushing that piece as well, and then emulsifying the lens pieces. Again, these are such dense lens pieces. Again, when you do this technique, you can feel how dense the lens piece is. It's like if you had your fingers and you were squishing a piece of rice, you can feel the softness of the rice between your fingertips. But if you had, a uncooked piece of rice, and you're pushing that between your fingers, you can tell it's hard. When you're chopping these dense lenses, you can feel how hard it is because as you bring the instruments together, they don't want to come together. But then as you squeeze the lens, suddenly there's a loss of resistance and the lens is fractured. And so, again, it's such a gratifying sensation. Again, very different from anything I've ever learned when I was doing cataract surgery. And that's why I started doing this technique and published this technique. And again, once I've moved to this technique, I've really never looked back. To me, it's really the most safe way to do cataract surgery. I feel like my complication rate is much lower as a result. My rate of PC rupture vitreal loss is much lower. I don't ever get corneal wound burns because of excessive ultrasonic energy at all, and I'm able to have clearer corneas after surgery. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Start subincisionally removing the cortical material, subincisionally, peeling from anterior to posterior, gently teasing it up and removing it, going around circumferentially, switching to polish mode, polishing under the rexus edge, making sure I don't grab the capsule in this situation, polishing the posterior capsule. You can see there's some stria in the posterior capsule as I grab it. So there's a little bit of zonulopathy in this case as well, as I suspected. When I get to the subincisional area, there's some fine material there I'm polishing off as well. And there's quite a bit of subincisional fine cortical material there. Trying to peel it with the polymer tip, but I might have to flush it. So this is the BSS cannula. I'm going into the subincisional space. And let's see if I'm able to pulse that material out. There we go. So some of that's coming out there. I'm really compulsive about cleaning up the bag. I don't want to have this patient come in years later with a giant Summerings ring or capsule phimosis. So I come out and I push viscoelastic, cohesive viscoelastic to fill the bag, and then I'm going to polish the lens epithelial cells under the rhexis edge, first on the left side and then the right side. You can see the single subincisional iris hook has been really a game changer for this case. This patient is not going to have iris trauma or transillumination defects or worsening potential post-op iritis from all that iris trauma. So I widen the incision with the blade because this is a 3-piece lens. I place it in, and because I have to push when I went in, I'm going to go ahead and push some more cohesive viscoelastic to fill the bag. Go ahead and deliver the leading haptic into the bag. Again, I do this with the bevel facing to the left. The optic comes out. I rotate counterclockwise 90 degrees. Optic comes out correctly. And then I'm going to use a Maltzman to dial in the trailing haptic. So again, when you're trying to deliver the lens, if the viscoelastic is coming out too much, don't hesitate to push more viscoelastic in, because you want a fully inflated bag when you're putting the lens in. If the bag is collapsed and you push the lens in, you can have a tear in the capsular bag. So I'm carefully taking that iris hook out, disengaging it from the pupillary edge, and then pulling it out. So I had to widen my incision. I have to be very mindful of iris prolapse here. So I go in with irrigation off, activate irrigation, remove the viscoelastic from within the bag. And the whole time I'm watching my incision, making sure the iris doesn't prolapse out here. I'll switch to visco mode, removing all the viscoelastic from the anterior chamber. Again, being very careful and mindful of iris prolapse here at this point, since I don't have that iris hook there anymore. And then I'll hydrate my incision. So again, this is a patient with a very, very dense lens, pretty big pupil, but it did show up as IFIS with iris prolapse. Reposited the iris. Again, you have to equilibrate the pressure. When the iris comes out, that means the intracameral pressure is so high during the hydrodissection. When I did it, decompress, and then I was able to reposit the iris back. I was able to make a small episcleral stab incision subincisionally, place the single iris hook. Remember that stab incision is still parallel to iris plane, and so it's a shelved incision, so it shouldn't leak or cause any problems. And even if it does leak, the conjunctiva is covering it, so the risk for a wound-related issue or infection is extremely low. And so you saw I was able to very carefully, mechanically fracture the lens pieces into smaller pieces, very controlled, systematic lens disassembly, reduce ultrasonic energy, enables to mindfully and carefully disassemble the lens without encountering any issues with the iris with the single subincisional iris hook. So I hope this was helpful to you, and I thank you for your attention.